So here's the thing. Most people who see the words labral tear on their MRI report assume that surgery is the next step. But by the end of this video, you'll know exactly how to tell whether that's true for your hip because it's going to take more than an MRI to answer that question. Now, the logic feels airtight. There is a tear, surgery fixes tears, so surgery must be the answer. But that logic skips the most important question. Why and how did your labrum tear in the first place? Skip it, and you can have the operation, do everything right in recovery, and still be in pain 6 months later, wondering what went wrong. Now, stay with me because one of the checks I'll show you is a step that most patients never get. I'm Dr. Mahmoud Almastri. I'm an orthopedic surgeon specializing in hip preservation, dual board certified in both Canada and in the United States, and I've treated more than 15,000 patients with hip disorders in the last 10 years. And so, starting off, the most common pattern I see in patients whose first hip surgery didn't work is this. The labrum was repaired, but the reason it tore was never addressed. So the tear then came back, or the pain never fully went away. So let's start with what a labral tear of the hip actually is, because almost nobody explains it the way it needs to be understood. Your labrum is a ring of cartilage that lines the rim of your hip socket. Its job is to seal the joint, keep the fluid in, and keep the hip stable under load. When it tears, that seal breaks. But here's the thing. A labrum doesn't tear on its own. Something forced it to tear. And in the vast majority of cases that I see, that something is usually one of two problems: hip impingement or hip instability. Impingement, FAI for short, means the ball and socket of your hip don't have the right shape. There's too much bone, essentially in the wrong place. So every time you flex your hip deeply, that extra bone pinches the labrum. The tear is then the result of thousands of repetitions of that pinching, not a one-time event. Now, instability leads to the same problem, a labral tear, but instability works the other way. The socket doesn't fully cover the ball, so the labrum gets stretched and stressed on every movement until it gives out. Because in reality, the labrum was never really designed to hold that load on its own. So if a surgeon repairs your labrum without also fixing the impingement or the instability underneath it, the same forces go right back to work on that repair. And that's the setup for a second tear. And it's the most common reason that outcomes fall short. Now, here's where the logic of I see a tear, so let's fix the tear really falls apart. Because if you take a group of adults with no hip pain at all and put them in an MRI, a significant portion of them will have labral tears on the images, but no pain, no symptoms, no idea. And this is well documented in the orthopedic literature. So a tear on your MRI is one piece of information, but it isn't proof that the tear is what's causing your pain. Now, pain level doesn't settle the debate either. I've seen a small partial tear leave someone barely able to walk. And I've seen a large complex labral tear in someone who functions at a nearly normal level, which is incredible. So how bad it looks on imaging and how bad it feels are related, but they're still two different things. Mix them up, and you end up operating on people who weren't ready and making people wait who perhaps needed surgery sooner, which raises the real question. If the image can't confirm it and the pain level can't confirm it, what actually tells you your hip joint is the source of your pain? Well, there's a diagnostic step that answers it directly, and most patients are rarely offered it. It's called a diagnostic injection, where a small amount of local anesthetic goes directly into your hip joint, guided by ultrasound or x-ray, so the doctor or the provider can watch exactly where the needle goes. And so if your hip is the source of your pain, that injection should give you significant temporary relief, often within minutes. If your pain doesn't change, your hip isn't the problem. The pain is coming from somewhere else, maybe your spine, maybe your SI joint, your sacroiliac joint, your pelvic floor muscles, or even a hidden hernia. And so this is how you confirm that surgery on the hip is the right answer for the right person. Because I've had patients come to me with no injection and no confirmation. But when we finally did that workup, we found out that the hip truly wasn't the source at all. And so those patients didn't need hip surgery, they did not need an operation, and they just needed a different diagnosis. And I've seen the opposite just as often. Someone whose pain got brushed aside for months, told essentially that it was all in their head, when a proper structural workup finds clear impingements in a real labral tear. And so the hip is the source, and once it's confirmed and treated, they got better. So same presentation on paper, two completely different answers. The difference was the workup. Now, if you've had the injection and it confirmed your hip, that matters too. And it means that the hip is a real player. But here's the caveat: it still doesn't mean that surgery is next. So, for me, as an orthopedic surgeon, the next question is, have you given targeted non operative care a real chance? Because physical therapy for impingement and labral tears is specific work, offloading the joints, building the muscles that stabilize the hip, and changing movement patterns in a safe way so that the damaged tissue is protected under load. In patients who just aren't surgical candidates yet, or who perhaps just need more time before surgery, the right therapy can quiet symptoms enough to restore real function. And that's why therapy comes before surgery. So here's what a strong surgery candidate looks like: it's four things. Number one, that the structural cause is confirmed on imaging, impingement or instability identified alongside that labral tear. Number two, a diagnostic injection confirmed the hip is the source, the real source. And number three, a real non operative care program was tried, but still did not give enough relief. And number four, the lack of relief or the symptoms in the hip and the groin are limiting daily life or sport in a real way. And so when all four line up, surgery can make sense. And when it's done correctly, fixing the structural cause at the same time as repairing the labrum, then that leads to strong outcomes. I treated an 18-year-old soccer player named Alex with growing pain in both hips. Injections confirmed that both of his hips were truly the source of the pain before surgery. So we did hip arthroscopy on both hips the same day, correcting the impingement and repairing the tear on each side. And he was back on the field playing soccer at around 4.5 months, and he eventually earned a college scholarship, which was great. Before that, his father was actually skeptical at first, before surgery, which is a fair position. But every piece of the diagnostic picture at the time just still pointed in the same direction. And that's what a good surgical decision looks like. So, what if the injection doesn't give you relief? Perhaps stop there. Now, your pain is real, but a different structure is causing it. And now the workup can go find it instead of sending you through surgery that won't help you. So, back to the question that you clicked on: does your labral tear need surgery? One of those four criteria checks the boxes. Whether your symptoms are really limiting your life, you already know. Now, the other three are answers you have to go get. You need the imaging that identifies the structural cause. Is it impingement? Is it instability? Is it a little bit of both? Where's the extra bone? Or is there missing coverage? You need a diagnostic injection confirming the hip joint is truly what hurts. And you need to have given a real, targeted, non operative program a fair shot. Unless your structural problem is so severe that therapy clearly isn't going to be enough. And so when a surgeon recommends hip surgery, you're allowed to ask directly, what's the structural cause of my labral tear? And how are we fixing that at the same time? Now, have we confirmed that the hip is the pain source for sure? And what's the plan if I'm not ready for surgery yet? And look, those questions don't make you difficult. They just make you thorough. And a surgeon who takes them seriously has already done this thinking. All of this hangs on one idea: that the MRI can't make this decision on its own. So if you want to go deeper into that, I made a whole video on what your MRI can and can't tell you about your hip and why I stopped relying on scan results alone. This video gives you the check boxes. That previous one shows you the scan's blind spots. So go watch it next. If this is the kind of thinking you want more of, subscribe. Every week, I break down the decisions hip patients are being asked to make without clear answers. Your labral tear didn't tear for no reason. Something structural forced it, and structural problems can be found, confirmed, and corrected. I'll see you in the next video.